All right, I have 12 o'clock, so why don't we go ahead and get started? I want to welcome everyone to Medical Grand Rounds at the University of Colorado. And I have the honor and privilege and pleasure of introducing several of our chief medical residents today who are going to give grand rounds this afternoon. Before I do that, I just want to have a couple of reminders. As always, please remember that you can use the link that Kelly puts in the chat to claim CME and mock credit for all grand rounds. And were you to attend all medical grand rounds in a year, it would be more than the mock credits you need to re-up your ABM certification every couple of years. I also want to let you know that if you have questions for our chief residents as the talk is ongoing, please use the Q&A feature within Zoom. I normally would say that the chiefs and I will gather that information, but it'll be me today, and I will make sure to gather all questions for our chiefs and ask them at the end of the talk. So please put those in as the talk is ongoing. I want to also remind everyone that Kelly will also place in the chat medical grand round nominations for 22-23. So for the upcoming academic year, those are due by the start of next week. We're going to start selecting grand round speakers toward the end of next week. So please get your nominations in either using that form or through your division heads. And then I want to also just remind people that COVID guidance has changed recently, not within the hospitals, within the medical campus itself. It does not mean we are in person for grand rounds yet. We'll stay virtual for the rest of the year, but it does mean that outside the hospitals, we can see the lower halves of each other's faces, which has been lovely for the past several days. And now I want to introduce our speakers. I will start, I'll go alphabetical here. I want to start with Dr. Cassandra Duarte. She is one of all of our speakers today are chief medical residents. She's a graduate of Wellesley College, where she graduated cum laude with a degree in biological chemistry. She then did her medical school training at Brown University in Providence, Rhode Island. And in between those two things, she spent 2 years as a consultant and innovation advisor at the U.S. Department of Health and Human Services. She's a member of our categorical track and our clinician educator pathway, and will be staying here at Colorado for an oncology fellowship next year. Our second speaker is Dr. Catherine Gwynn. She is a graduate of Colorado State University in Fort Collins, where she majored in biomedical sciences and was part of the University Honors Program. She then came here for medical school to the University of Colorado, where she trained in the rural health track. She was a member of our primary care track as a resident and the health equities pathway. And she'll be returning to Missoula, Montana next year to work at Providence St. Patrick Hospital, which is only one of 2 training sites in the entire state, continuing her goal to bring improved medical education and training to the state of Montana. Dr. Jason John is our third speaker today. He's a graduate of Texas A&M University. He also graduated magna cum laude with a Bachelor of Science in Microbiology and Nutritional Sciences. He then did his medical school training at the University of Texas Health Sciences Center at San Antonio before coming here for his residency. He was a member of our hospitalist training program and the clinician educator pathway. And we are lucky that he is staying on as a member of the Division of Hospital Medicine starting next year at University Hospital. And then our fourth speaker is Dr. Michelle Knies. Michelle is originally from Colorado. She's a graduate of the University of Colorado at Boulder. She also graduated magna cum laude with a Bachelor of Arts in Integrative Physiology and Neurosciences. She attended medical school at Midwestern Chicago College of Osteopathic Medicine. And she spent a number of years doing very interesting things in the world before we got her to return here to Colorado. She is on track to get her Lean Six Sigma Yellow Belt this summer. As part of her training, she was our chief resident in quality and safety this year. Michelle was a member of the hospitalist training program and our health equities pathway. And like Jason, will be staying as a member of the Division of Hospital Medicine and also working at University Hospital. I don't have time to give you the accolades of this incredible group of young physicians, but they really are remarkable. And I am very excited to listen to their talk about the evolving role of the resident physician.
Awesome. Thank you, Dr. Connors, for that introduction. Welcome, everyone, to Grand Rounds. Our talk is titled The Evolving Role of the Resident Physician. And this talk will be given by myself, Cassandra Duarte, and my co-chiefs, Catherine Gwynn, Jason John, and Michelle Knies. So we have no financial disclosures to report, but we do acknowledge that though we all went to different medical schools across the country, we have all trained here at the University of Colorado Internal Medicine Training Program. So this talk comes from our experiences as residents here, and we acknowledge that things may be different elsewhere in the country. Our learning objectives for this talk are as follows. First, we aim to compare and contrast internal medicine residency training program competencies from the past and the present. Second, we plan to analyze contemporary core competencies of an internal medicine residency training experience. And third, We would like to challenge how these competencies align with the changing role of the resident physician and propose a new direction forward for training. In order to achieve those objectives, here's how we will go through this talk. We will first start with an introduction to a patient case, then speak on the history of the ACGME. We will then spend the bulk of our talk comparing and contrasting 3 ACGME core competencies for internal medicine training across the last 20 years. Then we will speak on how these competencies align with the changing role of the resident physician and propose a new direction forward for training. So, a word on our timeline. During this talk, when we refer to the past, we will be discussing training that occurred around the year 2000, as this is when our patient case is from. When we speak on the present, we will refer to the time around the year 2022, and for the future, we will look forward 20 years to 2024 or 2040. So it wouldn't be a medicine conference without a patient case. This is a chart from a patient cared for at Denver Health in the year 2000. He was a 70-year-old male admitted for chest pain, found to have an NSTEMI requiring CABG. This note is from a few months after he was admitted, when the patient is readmitted to the hospital with a new diagnosis of acute decompensated heart failure due to his ischemic cardiomyopathy. You don't have to read each point in this note, as we will continue to refer back to it throughout the talk, but I wanted to give you this patient's one-liner for now. And now I'll hand it over to Dr. John.
Thank you, Dr. Duarte. We'd like to start by going through a broad 30,000-foot overview of the history of medical residency training with a short timeline. The first date that you see here is 1889, and that was the year that the Johns Hopkins Hospital opened, and physician-in-chief William Osler recruited members of the first medical residency program, modeled after German teaching hospitals. This intensive teaching at the bedside ensured that new medical graduates had several years of practice with all kinds of cases and were well-versed in the current medical practices, including clinical laboratory work. Next, as we move forward to the 1950s, and as a snapshot of the era, Dr. Eric J. Castle reflected on his own training at Bellevue Hospital. He says, the era of technological revolution in medicine and the era of therapeutic efficacy was just beginning. There were no intensive care units. Cardiac, pulmonary, and renal resuscitation did not exist. Cardiac catheterization had just started. As an example of the state of the art, in 1954, one of my patients was to be treated experimentally with intravenous streptokinase for his recent coronary thrombosis. He was a derelict with no family and from whom no permission was obtained. We were to monitor his progress by ECG every few minutes. I made the electrodes from quarters, silver at the time. After a few hours, the experiment was stopped out of fear for the patient because of frequent ventricular premature beats. This is how residency was and would continue to be for several decades. Residents worked in the hospital for a number of years, and at the end of it all, they were expected to be proficient, independent doctors. In time, however, a need to standardize such training became apparent. One way to do this was program accreditation. In 1982, the ACGME formed 1 year prior to, quote, improve healthcare by assessing and advancing the quality of resident physicians' education through accreditation, published its Essentials of Accredited Residencies and Graduate Medical Education, which included a set of general requirements for programs. In 1999, the ACGME selected and endorsed 6 core competencies to define foundational skills every practicing physician should possess. And then in 2013, the ACGME developed internal medicine milestones to provide a framework for the assessment of the resident in key dimensions of core competencies. Version 2.0 of these milestones went into effect just this past year. Speaking of the ACGME core competencies, here they are. Patient care, medical knowledge, systems-based practice, practice-based learning, and improvement, professionalism, and interpersonal and communication skills. During today's talk, we'll take a deeper dive into the first 3. We are choosing to do so for the following reasons. Patient care, because even though it has always fundamentally existed, the way we have gone about delivering it has changed dramatically. Medical knowledge, because of the exponential growth in its sheer quantity, which does not simply trickle, but often pours upon trainees. and systems-based practice, because although one of the original 6 core competencies in 1999, it is something that is much more at the forefront of the contemporary residency training experience compared to its nascent years. Let's start with patient care. Patient care is central to residency training and beyond. And it's pretty self-explanatory, but to be clear what we are talking about here, we're talking about history, where the ACGME has specific language about historical subtleties based on patient, family, and system needs, and using it to guide diagnostic testing. We're talking about physical exam, which should be evidence-based and for which residents should have understanding of predictive values for certain maneuvers. Clinical reasoning, which includes prioritized differential diagnoses and complex presentations and recognizing errors in one's own reasoning. And then, of course, patient management itself, both inpatient and outpatient, and that which is comprehensive includes management of complex, rare, ambiguous, and subtle presentations, and integrates recommendations from multiple disciplines. And finally, digital health, including EMRs and telehealth, and involving design and innovation in these arenas. So let's talk about how patient care may be changing for the patient in our case. Here we see an inpatient team performing a volume exam on a patient in the traditional fashion. The progress note on this slide is the same one from our aforementioned case. And you can see the documentation succinctly notes jugular venous distension, bibasilar crackles, and bilateral lower extremity edema. Focusing on the physical exam aspect of patient care, let's talk about point of care ultrasound, an emerging area of focus in general internal medicine in both education and clinical care, and one that is increasingly ready for prime time, if not already so. In this same patient, the resident sonographer may have been able to identify a dilated, non-collapsing internal jugular vein, tracking it cranially. She also could have observed a plethoric and once again non-collapsing inferior vena cava. She may have been able to identify a B profile on lung ultrasound. Finally, she may have been able to capture this parasternal long axis view of the heart. How do traditional physical exam techniques and decompensated heart failure stack up against the addition of their contemporary counterparts? This table outlines positive and negative likelihood ratios for decompensated heart failure of various physical exam findings in a dyspneic patient. We'd argue that the addition of POCUS in this case is useful. Sonography of the IJ is particularly helpful in a patient where the JVP is difficult to appreciate with the naked eye, something I think a lot of us can relate to. Multiple trials have identified a dilated, non-collapsible IVC as an independent and statistically significant predictor of both readmission and mortality. And then in the setting of acute decompensated heart failure, a B profile on lung ultrasound is suggestive of cardiogenic pulmonary edema. Studies have demonstrated lung ultrasound to be more sensitive and specific than clinical workup, chest radiography, and BNP or NT-proBNP. And a specific multi-center prospective cohort study found lung ultrasound to have a positive likelihood ratio of 14. So if you want to compare that to the table, and a negative likelihood ratio of 0.1, again, comparing to that table on this slide. And then in no uncertain terms, full echocardiograms and nuanced diagnostic and management decisions based upon them still requires a cardiologist. However, features of this point of care ultrasound, namely the diffuse hypokinesis, decreased myocardial thickening, increased E-point septal separation, and left atrial enlargement captured on a parasternal long axis view of the chart or of the heart suggests to the properly trained clinician that in this otherwise undifferentiated dyspneic patient, left ventricular systolic function is reduced. So herein lies the question. At the end of the day, how are internal medicine residents being assessed on their physical exam skills? According to the ACGME internal medicine milestones, a level 4 resident, which is our target for graduation, uses advanced maneuvers to elicit subtle findings and integrates those subtle findings to guide diagnosis and management. The aspirational level 5 resident takes it a step further, modeling effective evidence-based physical examination technique and teaching the predictive values of examination findings to guide diagnosis and management. Considering such expectations, why might point of care ultrasound come to mind? In addition to improvements in diagnostic accuracy and time to diagnosis, studies have shown POCUS to be associated with reduced unnecessary testing and radiation exposure and increased patient satisfaction and understanding of the diagnostic process. Numerous studies have also affirmed desire by trainees for POCUS training. This is also one of the most common topics we get asked about by internal medicine residency applicants during recruitment season. Professional societies have put out position statements in support of POCUS training, including the American College of Physicians, the Society of Hospital Medicine, and the Alliance for Academic Internal Medicine. As for the ACGME, there is a long-standing core requirement in the common program requirements that residents must be able to perform all medical, diagnostic, and surgical procedures considered to be essential for their area of practice. And then making its debut in the latest version of these requirements, which go into effect in July of this year, the committee does acknowledge that offering point-of-care ultrasonography to residents who believe this will be relevant to their future career practice may be one way to meet the above-mentioned requirement. Where might POCUS be considered essential for an internal medicine resident's future area of practice? So you have to look no further than the University of Colorado Division of Hospital Medicine. New faculty are required, not suggested, not given the opportunity to, they're required to complete credentialing in lung POCUS within 1 year and focus cardiac POCUS within 4 years of their start date and maintain privileges thereafter. Now I will turn it back to Dr. Duarte to discuss the ACGME core competency of medical knowledge.
Thank you, Dr. John. The next core competency that we will discuss is medical knowledge. The ACGME states that in order for a resident to achieve an aspirational level of medical knowledge, they must be able to apply foundational knowledge in the biomedical sciences, specifically with regards to diagnostic testing, and also be able to apply this knowledge clinically to patient care. Let's go back to our patient case. If you remember, he had previously had an NSTEMI requiring a CABG and then was readmitted to the hospital for a heart failure exacerbation due to his ischemic cardiomyopathy. I have typed out the medical residence assessment and plan from the past year. Let's see how the growth of medical knowledge has changed heart failure management from the past to the present day. You can see here that the management of heart failure has become much more involved in the last 2 decades due to emerging research with novel therapies listed on red in this slide. While some things are similar, such as diuretics and beta blockers, we now have entirely new classes of medications to consider in our management of heart failure patients. 2 examples are angiotensin receptor neprilysin inhibitors, such as sacubitril valsartan, and sodium glucose cotransporter 2 inhibitors, such as empagliflozin. Additionally, we also consider the need for devices, including ICDs or cardiac resynchronization therapy in our patients. For the management of his coronary artery disease as the underlying cause of his heart failure, there was no discussion of lipid management when he was originally admitted to the hospital. Now, in addition to statin therapy, we also offer other medications such as ezetimibe or a PCSK9 inhibitor. And additionally, if this patient had undergone stenting instead of coronary artery bypass, we may have had to consider his genomics and CYP2C19 genetic status when prescribing dual antiplatelet therapy, something that was not done until recently due to advances in genomics. One challenge to being a resident in today's day and age is the explosive growth of medical knowledge. While this may be a difficult statement to quantify, I'd like to walk through a few examples that will help us grasp the growth of medical knowledge that has happened over the last 20 years from when our patient was admitted to the hospital up until now. For one example, let's review Harrison's textbook of internal medicine. Originally published in 1950, the first edition of this textbook was considered the premier textbook for internal medicine physicians. However, since 1950, we have reached over 20 editions of this textbook with now almost 400 chapters spanning 2 volumes instead of 1. The editors of this book note in the preface of newer editions that they thought, quote, peptic ulcer disease was thought to be caused by stress. Nearly every tumor that was not resected led to death. Rheumatic heart disease was widely prevalent, and hepatitis B and HIV infections were unknown. Now, there are new chapters in this book that cover topics in medicine that did not exist back in 1950 or even in the year 2000. Some examples of this might include sex and gender-based issues in medicine, obesity, diabetes, and metabolic syndrome, consultative medicine, epigenetics and health, and worldwide changes in patterns of infectious disease, to name a few. It's also important to realize that this textbook is no longer just 1 volume, It comes in 2 books now, and consumers will get access to any online resources through Harrison's as well. Looking more broadly at the growth in medical knowledge as a whole, you can see this graphic from a 2015 JAMA article that the amount of data being created by the medical field is continuing to grow year after year. This graphic depicts the increase in the total number of medical research articles from the year 2000 to 2009, broken down by country of origin of the publisher. You can see we went from just over 320,000 articles to 367,000 articles in about 10 years. To break that down even further, that's about 4,500 new articles per year for 10 years, or 12 new articles a day to be read if you were to keep up on all medical knowledge that came out over this time frame. In a 2016 article by the Harvard Business Review, the authors Dr. Chin and Mr. Satel note that the exponential growth of medical knowledge will be the largest barrier to improved patient care facing physicians due to our limitations in knowledge acquisition as individuals. Let's look at this idea of medical knowledge with regards to the patient case that we started our talk with. So, from a quick review of the major trials regarding new medications for heart failure and cardiovascular disease, there are at least 11 new articles that residents need to be familiar with if they are to provide effective patient care given updated medical knowledge. This is not counting the other 18 landmark trials in heart failure management that would have been published by the time this patient was admitted to the hospital in 2000 and would have helped to guide decision-making in the initial assessment and plan, for a grand total of almost 30 articles that a resident would need to read about the management of heart failure due to ischemic cardiomyopathy. This is only one of hundreds of conditions that we learn to manage and diagnose during residency. I encourage you to imagine how many new medications or interventions will be available to manage heart failure due to ischemic cardiomyopathy in the year 2040. This tremendous increase in the amount of medical knowledge available to physicians will undoubtedly make it difficult for us physicians to remain up to date on all guideline recommended therapy for every condition we come across in practice, especially for practitioners who are in generalist fields such as hospital medicine or primary care. So, how do we ensure that our medical residents here at the University of Colorado are kept up to date with the expanding knowledge landscape? Our program has historically done this in a few different ways. The mechanisms of teaching residents included things like bedside teaching, morning report or noon conference, which is usually case-based, chalk talks that were given in the afternoons by residents or their attendings, and then a residency-wide journal club. Now, although we still use all of those methods to educate residents, we also have different ways. For example, we have residency pathways that allow residents to further build their knowledge in fields such as medical education or health equities. We have instituted formal education programs, such as our Wednesday education session, where we review not only pertinent pearls in clinical medicine, but also cover topics such as wellness, diversity, equity, and inclusion. We have standardized outpatient education sessions and specialized journal clubs based on our residents and their tracks. We also provide residents with an educational stipend to purchase resources and give them a conference stipend to attend conferences throughout their training, in addition to providing them with access to the New England Journal of Medicine Knowledge Plus database to assist in board review. If you recall from our discussion of competency and medical knowledge, acquiring medical knowledge is only one way in which competency can be achieved. The second component includes being able to apply knowledge clinically. The photo you see here is one of our former third-year residents, Dr. Iyengar, presenting in the Denver Health MICU during the time of COVID. During the last 2 years, new literature has come out nearly daily on the management of COVID, and our residents have proven that they have been able to not only read the literature, but apply it directly to patient care and the countless COVID patients they have cared for in the last 2 years. While dissemination of medical knowledge is not inherently written into the ACGME core competency of medical knowledge, it is understood that residents are also responsible for teaching others the knowledge they have obtained. Residents do this in a variety of ways, but perhaps the most obvious example of how residents teach others is in their interactions with medical students. In a 2007 survey conducted by the Walter Reed Medical Center of residency training programs during the years 2004 to 2005, of which the University of Colorado was one of the survey distribution sites, it was found that medical residents spend on average anywhere from 5 to 10 hours per week teaching medical students. When medical students in this survey were asked, quote, "In what setting are you most likely to be taught by residents?" End quote, 92% of medical students responded, stating that they were most likely to be taught by residents on the wards. Our residents interact with medical students every day, and with current changes proposed to the School of Medicine curricula, we can expect to be working with more students across almost all clinical practice areas. This is just an example form of something that residents might be asked to fill out when they're working with medical students to help evaluate them. And additionally, residents are now responsible for editing and attesting the notes of medical students, so we can use them in our billable encounters. And this undoubtedly requires more time and attention to the oversight of our medical students and their work than previously before. So how do we evaluate medical knowledge for CU residents? This is a screenshot of one of the questions we use to evaluate residents' medical knowledge at our program. You can see here that a level 4 or level 5 resident must be able to integrate scientific knowledge to address uncommon, atypical, or complex comorbid conditions within the context of multisystem disease. And this is for the category of applied foundational sciences. For now, I'll hand over the talk to Dr. Knees.
Thank you, Dr. Duarte. We're now going to transition to the third and final ACGME core competency that we'll discuss in detail today, which is systems-based practice. The third competency is unique in that prior to 2000, there was minimal awareness of both patient safety and social determinants of health as they related to overall patient care. So we'll start by discussing the first of the system-based practice milestones, which is patient safety and quality improvement. Let's apply this principle to our case. Imagine our patient was admitted to a teaching service in the year 2000. The intern just read a novel and practice-changing study in The Lancet, which showed that metoprolol can be used to reduce mortality in chronic heart failure. So they write a new prescription for metoprolol tartrate 100 milligrams on admission. Unfortunately, they're unaware that starting a new high-dose beta blocker when a patient is acutely decompensated can lead to cardiogenic shock. Our patient's cardiac output drops and he ends up requiring a prolonged ICU stay. Prior to 2000, the intern may have been reprimanded by their attending, but it's unlikely that a meaningful system change would have occurred as a result of this error. Morbidity and mortality conferences, when they did occur, tended to take place within the surgical and anesthesia realms. They occurred within a name, blame, and shame framework, which analyzed or critiqued a physician's decision-making process. Physicians, including leadership within our own program, described the process in one word, which was scary. However, the landscape for discussing healthcare errors started changing in 1999 when the Institute of Medicine published the groundbreaking book To Err is Human. With the assertion that 44,000 to 98,000 patients die each year due to medical errors, the report caught the attention of the medical community, the media, and the general public, and is now considered to be the birth of the formal patient safety movement. Although some have criticized the way that the data was collected and reported, the documented created a framework for analyzing patient safety occurrences, which included the assertion that patient errors occur not due to bad people, but rather good people working in a bad system, which needs to be made safer. The ACGME then published its first core competencies, one of which was systems-based practice with a focus on patient safety, the same year that this book was published. So let's now transition back to our patient in 2020. Our intern again makes a mistake and prescribes a high dose of metoprolol, pushing the patient into cardiogenic shock. Because internal medicine M&Ms occur on a monthly basis at both the university and the VA, an M&M is scheduled and brings together physicians, pharmacists, and nurses to discuss not only the cognitive factors which led to the patient error, but more importantly, the systems factors which allowed the error to reach the patient. The intern is kept anonymous and the conference is conducted within a no-blame framework with the goal of working together to prevent a similar error from occurring in the future. This is a fairly recent occurrence. Our residency started conducting our monthly M&Ms in the year 2014, but they've become one of the primary ways that we teach patient safety concepts and encourage residents to approach safety errors with the goal of identifying system level factors. In an average month, residents in our program will receive 20 new conferences, 1 to 2 of which generally include a dedicated morbidity and mortality conference. In addition to M&Ms, residents also now receive formal didactic training and quality improvement. In 2015, quality curriculum was designed and implemented within our residency program. At a minimum, we now expect our residents to engage in a longitudinal quality improvement project in their continuity clinic, and they do receive dedicated didactic time for this quality improvement project. Similarly, they engage in formal QI didactic sessions during their Wednesday educational sessions, and the GME bonus program this year specifically involves attending 2 collaborative case reviews, which are similar to M&Ms. In addition, the GME bonus program encourages the filing of patient safety reports, which can take 15 to 20 minutes to properly input. Within the past 20 years, training in patient safety and quality improvement has gone from essentially non-existent to occupying a core component of residency training. So how does all of this fit into these ACGME core competencies and milestones? According to the ACGME, achieving a level 4 is a graduation target. Achieving a level 5 is aspirational, and this is a resident that can serve as a model for others. To achieve the ACGME's graduation target, an internal medicine resident is expected by the end of their residency to do the following, and this is no small task. They're expected to be able to conduct an analysis of patient safety events, offer error prevention strategies, disclose patient safety events to patients, and have the skills to identify, develop, implement, and analyze a quality improvement project. And again, this is just the expectation to graduate. An aspirational resident should be able to do all of this, but also lead patient safety teams and work within the community to institute quality initiatives. Given that most hospitals employ dedicated patient safety committees and quality specialists, this is certainly no small task to ask of our residents. I'll now pass it off to Dr. Gwynn, who's going to discuss the remaining aspects of the systems-based milestones.
Thank you, Dr. Knies. Now let's focus on system navigation for patient-centered care and the physician role in healthcare systems. Specifically, in the system navigation subcompetency, we will look at part 2A, 3B, which reads, quote, programs must understand the social determinants of health of the populations they serve and incorporate them in the design and implementation of the program curriculum, with the ultimate goal of addressing these needs and health disparities. Within the physician role subcompetency, we will look at what the ACGME internal medicine milestone considers a level 5 resident, which reads, quote, advocates or leads system level change that enhances high value, efficient, effective patient care, actively engaged in influencing health policy through advocacy activities at the local, regional, or national level. Let's start by looking at a note from 2000. This is the pre-templated social history on the left and the plan on the right. Please note that there's no mention of social determinants of health, a core competency now required in this plan. Anecdotal conversations with attendings who trained during this time period mentioned there might be informal comments made around things such as, it might be hard for a homeless person to take their meds, but there was no formal training on the social determinants of health here at CU or what to do about them. And so the question lies, why do social determinants matter? As a physician, we study and strive to improve our patients' quality of life and length of life. This graphic from an organization from the University of Wisconsin defines this as, quote, health outcome, as seen in the top of the graphic. The graphic summarizes a large quantity of data over the last couple decades that reveals about 20% of a patient's health outcome comes from clinical care. Medical education has historically focused on clinical care, and while we must remain that physicians should stay experts in the clinical care space, physicians must expand their leadership and focus to include all aspects of a patient's health outcome to achieve our goal of improving patients' quality of life and length of life. To impact a larger portion of a patient's health outcome, physicians must consider their physical environment, such as housing and air quality, social and economic factors, such as education and social support, and health behaviors such as drug use, diet, and exercise. Now let's focus on how this area of social determinants of health came to become a core competency of medical training. When do we start talking about social determinants of health? Many people point back to the year 2002. This is when the National Academy of Medicine report, Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, made front page news when released in March of 2002. This paper documents how a person of color experiences a healthcare environment and how treatment disparities arise in healthcare systems, and offered recommendations on how to improve patient care. And to the right is the CDC's Healthy People 2010. The CDC defined two overarching goals to increase the quality and years of healthy life and to eliminate healthcare disparities, which the CDC expected to serve as the guide, expected to serve to guide the development of objectives that would be used to measure progress. Now let's fast forward to today's note, where residents are expected to accurately screen, identify, and create plans for different aspects of the social determinants of health. In this note from a similar patient from Denver Health, the resident was able to identify his uninsured status, tobacco use disorder, housing insecurity, and food insecurity as medical problems that will greatly impact the patient's health outcome. While we maintain it is important to get this patient on goal-directed medical therapy for their heart failure, we must also lead the discussion with our multidisciplinary team on how to improve the patient's health outcomes by addressing their social determinants of health as a sector. Residents learn social determinants of health through multiple places here at CU. While we have dedicated didactics in WES, the ambulatory teaching on the social determinants of health, the residency is actively increasing didactic education through new conferences and bedside teaching. Personally, most of my education on the social determinants of health was learned experientially while working with our multidisciplinary teams. Specifically, Inpatient, we have daily multidisciplinary rounds in which we meet with a case manager, a care coordinator, a social worker, an RN, a pharmacist, and either a physical or occupational therapist. Or at our Denver Health Medical Home Residency Clinics, the interprofessional team is made up of care coordinators, a pharmacist, an addictions counselor, mental health provider, nurse, medical assistant, physician, lifestyle coaches, and psychologists to improve a patient's diet and exercise, and patient access specialists. Through each of these multidisciplinary teams, each provider is able to perform at the top of their license and collaborate on how to improve. Now let's briefly take a look at how these residents are evaluated on system-based practice 3. This is a screenshot of a current internal medicine resident evaluation in clinic. She is reaching level 4, again defined as the degree of competency necessary to reach graduation, which is in that she's consistently able to advocate for patient care needs with a consideration of the limitations of each patient's payment model for the 14 patients she is scheduled to see in clinic that day. Now let's zoom in on the level 5 competency, in which residents here at CU, based on the ACGME internal medicine milestones, are expected to actively advocate for systems level change at the institutional level of health policy and changes of the community level or beyond. CU's evaluation is actually scaled down from the ACGME internal medicine milestones, for which it states residents are, quote, actively engaged in influencing health policy through advocacy activities at the local, regional, or national level. This concludes our review of the first 3 competencies. As a reminder, we chose these 3 competencies as they have changed the most over the last 20 years. As Dr. John showed us, patient care has increased in quality. Dr. Duarte showed us that the data on how medical knowledge has increased in quantity. And Dr. Kaniz and I analyzed a couple aspects of system-based practice, which have been newly created over the last 20 years. As a reminder, we will not discuss practice-based learning and improvement, professionalism, interprofessional communication skills. I will now pass the discussion back to Dr. Kaniz.
Thank you. So we're now going to move on to the next phase of our talk, which is going to discuss the evolving role of the resident physician and where we go from here. So hopefully over the past 30 minutes, we've demonstrated how the requirements for becoming a competent resident physician have both grown and expanded over the last 20 years. Our question for you, the audience, is to what extent are old adages still applicable? For example, William Osler, the founder of the first residency training program, noted that medicine is learned by the bedside and not in the classroom. Let not your conceptions of disease come from words heard in the lecture room or read in a book. See and then reason and compare and control, but see first. However, as Dr. Duarte noted, the majority of medical knowledge is no longer gained by the bedside. In fact, residents now spend the majority of their time on computers, speaking with consultants or engaged in formal didactics. Dr. Osler similarly noted, the young physician starts life with 20 drugs for each disease, and the old physician ends life with 1 drug for 20 diseases. While the sentiment of this quote remains salient today, as we exemplified with our modern day heart failure patient, there may in fact be 20 evidence-based drugs for a patient's complicated comorbidities at the time of discharge. So what is a modern day physician? As it currently stands, we are training our residents to be excellent bedside clinicians, much like clinicians of the past. However, we also expect them to know how to use modern technologies such as ultrasound, to conduct and publish scholarly activity and research, to educate their medical students, peers, and patients, to engage in advocacy at a local and national level, to become patient safety champions and conduct quality improvement initiatives, and to engage with their patients holistically to identify and address the social determinants of health in addition to their medical comorbidities. All this while still spending increasing amounts of their day documenting increasingly complex patient care plans and the electronic health record. So with all of these additional expectations and requirements, the question we again pose is to what extent are old adages still applicable? What are the true core competencies an internal medicine resident needs in order to be considered proficient in their field?
As the competencies of a resident evolve, so must the expectations we have as residents. For example, take this 2003 paper in academic medicine, which looked at how to improve the proficiency of residents performing microscopic urinalysis. Because, quote, urinalysis is widely used in clinical practice, and micro-UA is a recommended procedure to be taught during the IM residency, end quote, with them referencing the 2000 program requirements for residency education in internal medicine. Now, 20 years later, not only is micro-UA no longer part of the IM program requirements, but it is not part of our curriculum and no one expects an IM resident to attempt this skill. We entrust that to our renal colleagues. Additionally, we are not expected to draw our own blood, insert IVs, transport patients, or do our own blood smears, to name a few. Currently today, medication reconciliation is getting removed from the residents' expectations. This 2015 meta-analysis in BMJ, looking at 17 studies involving 21,000 patients, showed a statistically significant 67% reduction in adverse related hospital revisits, 28% reduction in ED visits, and 19% reduction in hospital readmissions when pharmacists conducted the medication reconciliations compared to physicians. We see this at UC Health, where there's a MedRec team that verifies a patient admissions medications, including calling their home pharmacy to ensure medications were actually picked up. Or at the VA, when a pharmacist meets the patient at bedside on discharge to counsel a patient on their discharge medication list. At this point, we do not know what data will direct changes of the future. Currently, there's more data coming out surrounding the use of scribes in residency training. Emergency medicine residency programs have used scribes for a number of years. A 2017 study published in the Journal of Graduate Medical Education, looking at implementation of scribes in the academic emergency department, revealed a statistically significant difference in increased resident interaction with faculty, more face-to-face teaching with faculty, increased faculty supervision for procedures, and decrease in delay in dispo. Similar studies have been published in dermatology, family medicine, and surgical subspecialties. There's a dearth of studies looking at the role of a scribe in internal medicine residencies. So let's instead look at this 2018 article in JAMA Internal Medicine, for which I will discuss. So please, I want you to look at your eyes to the right part of this chart. In particular, this was a 12-month crossover study in which attending PCPs were randomly assigned to scribe or no scribe for 3 months and alternated exposure for 1 year, thereby serving as their own controls. I want to specifically point out that the scribe periods were associated with a higher likelihood of a PCP spending more than 75% of the visit interacting with their patient and less than 25% of the visit on a computer. Now let's look at this 2019 direct observational study published in JAMA. For every 24 hours of clinical care, residents spend about 3 hours at the bedside providing direct care, as noted in the table to the far left. About 16 hours per 24-hour period was spent on indirect care, 10 hours of which was spent charting. How are residents supposed to learn the increased quality of patient care with techniques such as POCUS when only 3% of their time is spent on patient evaluation or management? Or learn the increasing quantity of medical knowledge when only 0.2 hours of their day is spent reading about medicine? Lastly, when is there time for them to create, implement, and assess sustainable quality improvement initiatives at the institutional and community level and actively engage in health policy through activity levels at the national or regional level, as they're currently getting evaluated on the internal medicine milestones? The big takeaway I want you to gather from the study is that far too much time is spent in residency interacting with the medical record, and more data, innovation, and study is needed to determine how to decrease this invaluable time. We propose that perhaps medical scribes should become commonplace for residents and attendings to spend more of their time providing direct patient care, leading the multidisciplinary medical team, and improving the field of medicine through their projects in research, QI, and advocacy work. Now I will pass the discussion back to Dr. Duarte.
Thank you, Dr. Gwynn. We'll now move on to one of the final phases of our talk. During our talk, we reviewed the core competencies of patient care, medical knowledge, and systems-based practice. We hope we have illustrated throughout this talk that the competencies set forth by the ACGME may need to be readdressed given how the role of the resident has evolved. So we propose the following as examples of adjustments to the internal medicine core competencies. For example, with patient care, now it is no longer reasonable to evaluate a resident based on their ability to do, quote, subtle exam maneuvers. We must instead evaluate residents on an evidence-based physical exam that may grow to include other modalities such as ultrasound. As patient care grows in quality and complexity, we believe this competency must reflect that as well. For the core competency of medical knowledge, it is clear that no one resident will be able to master all clinically relevant knowledge to provide effective patient care. If we are using residency to ensure that trainees are ready for independent practice, then perhaps we evaluate not only one's fund of medical knowledge, but also their process to continuously add to and refine their medical knowledge, given that the continued growth of data will be an important factor for us to learn to deal with in the future. Similarly, we expect residents to be effective educators, not only for their learners and colleagues, but also for their patients, as we acknowledge the role of health literacy in patients' understandings of their own health conditions. Therefore, we propose a new competency that could be created to evaluate residents on their ability to disseminate their medical knowledge, which could be based in educational theory. For systems-based practice, the competency as it stands now expects the resident to understand many detailed aspects of patient safety and QI theory. We propose that while it is important for residents to have an understanding of QI, we no longer expect everyone to become a master in QI with the growth of other areas for specialization, including health equities and medical education, to name a few. Therefore, we propose a reduction in the expectation of residents with regards to QI to better reflect what is truly expected of them. Now I'll pass it off to Dr. John to discuss the future design of training programs.
Thank you, Dr. Duarte. To wrap, let's talk about future directions in internal medicine residency training. How do future residents become aspirational in their desired field? And it is our belief that a key aspect of becoming aspirational in your desired field is the ability to customize your residency training experience. And here at the University of Colorado, we currently do that in a few different ways. All the residents in our program belong to a track: categorical, hospitalist, primary care, or physician scientist, and choose a pathway: global health, health equity and disparity, medical education, medical leader, or research and investigation. As you can see by this matrix, this alone creates 20 distinct training experiences. We've also transitioned our schedule to a 4+4 model where classically rigorous wards and ICU months alternate with dedicated ambulatory and elective blocks, where residents have the time, freedom, and bandwidth to spend both more time in the clinical environments in which they someday hope to work, and also to gain knowledge and skills in extra clinical domains where being level 4 is simply not enough for them and their personal goal is to be aspirational. Speaking of electives, here's a snapshot of those that we offer in the current day. Again, really allowing our residents to customize their training experience. All of this is not to negate the foundational skills that we want all of our residents to develop to become excellent physicians. That's a given and something we want for every trainee that comes through our program. We simply hope to build bridges towards specific areas of expertise that individual trainees desire and may in fact need in their future careers. So with that in mind, where do we go from here? Where do we go next? And how do we deliver this customizability to future trainees in innovative and creative ways? Some ideas to consider, and this is truly food for thought. We can all brainstorm ways to recognize, enhance, and even create non-traditional undergraduate and occupational routes to medical school, including integrated programs. We can think about synergistic tracks, pathways, and electives in undergraduate and graduate medical education with an effective and frequently utilized line of communication between medical schools and residency programs. And then lastly, we can all think about giving trainees a greater degree of freedom to select or prioritize some components of their expected proficiencies, even if doing so shakes up the paradigms of core competencies, length of training, or even internal medicine residency as it looks today and as we know it. So this concludes our talk. We are so appreciative of the opportunity to speak today. We're really appreciative of your time and the fact that you sat here and listened to what we had to say. We are now happy to take any questions from the audience.
So to all of our chiefs, thank you very much. I certainly sat here and listened to all you have to say. I also realize I probably need to give you all some more days off because that is a lot. So what I'm going to do is, I don't know, the questions written by the audience, and we have more of those than we have time for, are probably just going to be directed to all of you. And then I'll let folks take the questions as they feel expert. The first question gets at something, Jason, that you mentioned in the last slide, and we got this question twice. Should medical training be longer? Is there just too much to teach in 3 years, which has been sort of the standard since, as you said, we transitioned from the German system?
Is it okay if I take that one?
Yeah.
And then you can fill in. This is
Sure.
something we actually discussed extensively while we were creating this talk. And one of our ideas was that potentially we should be grading our residents on competency-based milestones. And so once you achieve a milestone, you progress to the next level, rather than adhering to this very rigid 3-year training program where hopefully you've completed the milestones by the end of it. And some people might complete this training program in 2.5 years. Some might take 5 years. But I think that potentially this would allow for the creation of better rounded residents and also allow them to pursue some of their passions.
Yeah, I agree completely.
That's great. Thank you. There are a couple of questions. Well, there's one from our residents. Let's start there, which is, do you think there should be an ACGME milestone for teaching skills? So you mentioned that there were a lot of new things, but that teaching doesn't appear to have been included, even though it's something we do a lot of.
Yeah, I'm happy to take this question. So I agree completely. From that study that I posted, we spend on average up to about 8% of our time, if you assume an 80-hour work week, teaching others. And so I think that having formalized educational training and how to teach adult learners will be critical for residents going forward. And I think that's true for a variety of reasons. The first being that I think medicine was founded in this apprenticeship model. And so you taught someone what you knew, but as we sort of progress through time and have more data on how to best teach people, I think that we should be given those skills and then employ that when we're teaching students who are coming through. Similarly, I think that as our position as internists continues to evolve, like we are no longer the single person who's doing it all. Instead, we're becoming leaders who are managing teams. We have to know how to communicate information effectively to all of our teammates who have had a variety of training in terms of their background, what school is required for them. And so I think that providing residents, all residents, or at least a baseline of how to teach others will be critical going forward as the position of an internist changes.
Completely agree. There's a question, you used the word management in your answer there, Cassandra. There's a question here. Is there anything in the CU curricula, as you described it, that allows for management training? Because it sounds like, and the person asking the question says, it sounds like so much of it you do is managing other people and their areas of expertise, and that the doctor becomes the manager. Do you get trained in that, or do any residency programs train people in that?
I think there's a couple of ways. So the short answer is, I don't know if we get dedicated, management skills 101, like folks might get while they're getting their MBA. But I think there's a couple pretty deliberate aspects of our training where we touch on some of these skills. Certainly, the low-hanging fruit is our medical leaders program, where people get skills on, thinking of managing, large systems and large groups of people. For those outside of the medical leaders program, another one of our pathways, the clinical educator pathway. So that gets to managing a team of learners and meeting people where they're at from an educational standpoint. And then I think the other thing that I would point out is just the way that we kind of our philosophy as a program. So I always tell the interns, you learn how to be a functional doctor within your first year of residency. And that holds true in many cases. And you spend your second and third years really with working on those skills of managing a team, teaching, getting feedback in those domains, rather than like, oh, how was your physical exam that day? How was your presentation that day? A lot of the feedback we give our senior residents is how they're managing their teams.
We have a couple of questions. One that started with the word which I think was an exclamatory word, and another just started with exclamation points. So I'll read the exclamation points one. It says, do residents have to achieve mastery level 5 training in all of the domains to graduate? This seems incredibly difficult, even for seasoned attendings.
Do you want to take this? Yeah. The answer to that question is no, we do not. It is not the expectation to receive a level 5 in our evaluations. I think oftentimes the personality type that goes into medicine wants to hear that they're 5 out of 5 on all aspects, but that is by no means the expectation. Level 4 is what's considered the expectation for graduation or the goal. And I think that's part of our proposed future plan, is that people should really be able to focus which area, which niche they want to become exemplary in, which area they want to become a leader. Is that advocacy? Is that QI? Is that research? You name it. And then at that point, you should be a level 5 in that area.
And I think specifically speaking to the QI aspect, because this is my passion, and so it hurt me deeply to write that I think we should potentially be focusing less in residency on the teaching of this. And so This is one where a level of 4 is really hard to achieve. And do we need our residents to be quality and patient safety leaders within their hospitals by the time they graduate? And the answer is probably no. They need to have an understanding of patient safety concepts. They need to be able to engage in a morbidity and mortality conference. But unless they're going into some of these fields that require that training, it's probably unrealistic for us to be grading them on that scale. And so this is an area where potentially there's more customizability within our residency training programs to figure out what we actually need to be teaching to have somebody proficient in internal medicine.
Then the only other piece of commentary I would add is we're not in any way making the argument that we even want our residents to be aspirational in every single aspect of what it means to be a doctor. But you say it yourself, Dr. Carnes, when we're recruiting residents, we want leaders and innovators here. And to me, a leader and an innovator is that level 5 in whatever career path that they choose. And so we want to make sure that we're giving residents the bandwidth to become aspirational in level 5. And at least one or a group of competencies that they plan to utilize and become experts in during their careers.
That was great. Thank you. And I did wonder how you all slipped that line about less QI in with Michelle standing in the same room.
It was hard. I typed it and my heart broke as I was typing it.
We all got nervous when she started to say it, but
I got nervous even hearing it. So we have a question from Dr. Prochaska, who is one of our long-standing master educators here. And he wants to know, how could this new paradigm work in a low resource setting? Because a lot of what you talked about, scribes, ultrasound probes for all, et cetera, is a pretty high resource investment.
That is an excellent question.
I have a thought.
Yeah, if you want to start.
Particularly in low resource settings, maybe the first move would be to meet that low resource setting where it's at. And so to focus on the needs of that area. So while a rural program that may not have a large teaching hospital or big referral base may not be able to deliver, some kind of thing that is best served in a big academic medical center in the middle of a bustling city. I think it would be uniquely suited to train residents in the type of expertise and the type of providers that they need in that setting. So that's like my knee-jerk reaction to that question.
And I would agree with Jason. Like, let's say you want to pick a rural residency training, and perhaps that's not where you're expecting to learn the most robust POCUS skills, because there's a few POCUSes that are shared amongst all the residents. But perhaps they focus, as we're suggesting that residents do, that they become leaders in advocacy, and they help elevate the issues of rural patients. These are underserved rural patients on a more national level for advocacy work. And the residency programs themselves can specialize. Additionally, this is something where, with our advocacy efforts, national policy can help direct some of these resources to these lower resource settings. I know scribes are often used as pipeline programs to get people into medical schools. And this could be a more advertised way to make that happen.
And I think that our proposition for the future actually holds even more truth for rural areas. So if you are the only physician for 50 miles or 100 miles in your area, you should not be spending your time drawing your patient's blood and putting in IVs and doing all of that, because you certainly have other things that you'll need to work on in terms of leading and managing the team that's with you. And so I would argue that if you are a provider in a low resource setting, you can make the cost benefit analysis saying that having a scribe will actually free up more of your time to accomplish more in-depth or larger priority tasks to allow you to practice at the top of your license as a physician. And so I do think that the argument could be made that though it seems like an upfront cost for maybe some of these investments, it would actually pay dividends in the outcome for rural areas.
I like the idea of financially modeling these things and sort of speaking the language of the people who ultimately, as Dr. Petrasco points out, someone will have to pay for these things. Agreed. And then I'll give the last question to Dr. Sudarth, who one of your APDs, who you obviously know well. It'd be impossible to ignore the pandemic in all of this and the sort of the changes that it has foisted upon us. What do you think are the most significant ways that the pandemic has impacted resident education, present day, and then also as we think about it going forward in the future?
So that will be the next Chief Grand Rounds talk. So tune in approximately 1 month for a 1-hour discussion.
Okay, that is
In
fantastic.
all seriousness, I do think that it has forced residency programs to become more flexible in a very good way. And so with the advent of telehealth, which, the ACG specifically calls that as digital health, that's something that wasn't reimbursed before. And so I think that there's a national appetite for discussing innovative ways that we can provide healthcare in a much more meaningful way without having to be as standardized, where we are doing the same thing as a rural program as Hopkins, for example.
And I'll just quickly say one of the big transitions of, med school to residency is the focus becomes less on you, as you become part of the hospital system and patient care. And I think with a pandemic going on, that became even more so the case. And programs were really kind of, hindered in how they could add on all these other things to make the residency experience tolerable, meaningful, wellness inducing. So it took a real toll on residents, but as our co-chiefs will discuss it next month.
And I like the pandemic highlights one of our key tenets that we truly believe that patient care and medical knowledge is the basis for all internal medicine training programs. And so it is, not a surprise to anybody that during COVID, patient care was at the forefront of our minds, in addition to also increasing our medical knowledge in this novel disease state. And so I think that it hammers home the point that all of these sort of extras for like systems-based practice and professionalism and interpersonal communication, that to me is all extra that's asked of internal medicine residents, but the core of our training has been and always should be the patients who are at the center of it, with the knowledge that comes from research and innovation going forward.
I love it. I think that's a perfect last word. I like the teaser for next month's medical grand rounds, and that you probably forced Chris and Sam and May to up their game a little bit by answering some of their easier questions. So that was excellent. I know the Chiefs hear me say this all the time, but I don't know that the world always does. You all are incredible, and you're the future of medicine, and you're amazing. And thank you for this excellent talk. Really appreciate it.
Thank you.
Thank you.
Pleasure. Thanks.
Thank you all.